think I'm going to get started. Well, welcome everyone, and thank you for being here. I appreciate having you in attendance. I'm excited to tell you a little bit about vocal health and the role of a voice therapist. So I'm a speech-language pathologist, and I specialize in the evaluation and treatment of voice disorders. And I'm here at the Yale Voice Center at Greenwich Hospital. You're in my office, and you can see I've got my poster of the larynx. You probably can't see it that well behind me. I've got my keyboard, and I'm going to tell you a little bit about what it takes to become a voice therapist and what the role of the voice therapist is, and then we'll get into vocal health and the kinds of things that we treat here at the Yale Voice Center. All right, so I have no disclosures to mention. I want to tell you a little bit about me before we dive into this presentation. So this is a second career for me. Before becoming a speech-language pathologist, I was a professional singer and an actor for a little over a decade. I performed in Chicago. After performing there for a while, I moved to New York, performed in off-Broadway shows, concerts, readings, workshops, a variety of things. And around the country as well as abroad, I performed in Japan, Taiwan, and Austria. And as many people know, one of the realities of being an actor in New York is that you have side jobs. So during my career as a performer, I also had a bunch of other jobs. I was a standardized patient. So at the NYU School of Medicine, I would get assigned different characters, and I'd have to learn those characters, understand what their ailments were so that medical students could practice interacting with patients, and then we'd evaluate their bedside manner and their skills. I also worked as a tutor. I was a bar mitzvah service leader, and I also did some administrative work. And this is just some photos from my career as an actor and a singer. So just to give you a little sense of the kinds of things that I did. So my path to becoming a voice therapist. So I went to Northwestern for undergrad, and I studied theater and musical theater there. And when I was about 10 years into my acting career and I decided that I was considering what else might be out there, I decided to take some steps toward learning about speech-language pathology, and with the idea of that, this career to help people with their voices is something I'm interested in. So I took a handful of prerequisite courses, and I applied and accepted and went to New York Medical College to get my Master of Science degree in speech-language pathology. And while I was there, I was fortunate enough to do some research with a mentor there on vocal warm-up and rescue strategies. And I also did some research, and I'm still working on some research on accent expansion, which is work that we've done with people that are non-native English speakers that are interested in learning speech sounds to be able to be perhaps better understood by native English speakers. So that's some research that I did too, which was really interesting. And also from my background in acting of putting on accents for different characters, that's something I'm pretty interested in as well. After I finished my master's degree, I knew I wanted to become a voice therapist. So I applied to one of the few, the few clinical fellowship programs that are one-year training programs to become a specialist in the evaluation and treatment of voice and upper airway disorders. And I was very fortunate to get a fellowship spot at a place called the Lakeshore Professional Voice Center in the Detroit suburbs. And I spent a year there training with amazing mentors in the evaluation and treatment of voice and upper airway disorders. And there I also had experience doing singing voice therapy. So now I want to talk a little bit about how the voice works. So I have this photo here. Can she do it? Is it possible? So the answer is yes, it is possible. If she sings at a frequency that matches the resonant frequency of that object, of that glass, and she does it loudly enough with enough amplitude and intensity, it can shatter the glass. But unfortunately, I don't have a video of her doing it, but that would be pretty cool. So whenever we talk about speech and voice production, we think about these four subsystems of speech. So there is the respiratory system, our lungs. We have the phonatory system, that's what vibrates. Those are our vocal cords or our vocal folds. those vibrate and make a sound. That sound bounces around the space in our face in the resonatory system, and then we shape our mouth into different positions, and that's articulation and articulatory system. So when we're speaking very specifically about voice, we really think mostly about the bottom three, the respiratory, the phonatory, and the resonatory. So articulation gets kind of put aside when we're talking about voice in many instances, and I'll talk to you more about those three in a moment. So in order to make any sound, the first piece of the puzzle is you need a power source. So for example, with a violin, playing the violin, that power source is a person's arm. Then you have the oscillator, something that vibrates. In the example of a violin, that vibration is coming from the strings, right? They are vibrating. And then you have a resonator, a place for that sound to bounce around in. So in the case of voice production, the power source is coming from our respiratory system, the air that moves up. The vocal folds come together, and then because the air is moving, they start vibrating. So that's the oscillator. And then the spaces of our face are the resonators, and that space is what really shapes the sound that's coming off of the oscillator and allows us to perceive what we hear. So for example, if I say, ah, and then I say, e. So we perceived two completely different sounds, but everything from the throat down was identical, right? It was the exact same pitch, but what changed was that I changed the shape of my face, so the resonance was different, and that's why we perceived one to be an E and one to be an ah. So I think it's important to be able to identify what these different parts, how they can impact what we hear on the outside. So here's just a little diagram I like. This is the vocal folds vibrating. So we can often think of the vocal folds as there's a body, that's that red part, and then there's a cover. And so the body is the muscle that'll come together, and the cover is it's a layer on the outside that has extraordinary vibratory properties, and that's what really makes the vocal folds do what we think is amazing that they do, right? So oftentimes when we are thinking about what's happening in a voice problem, we're trying to identify, is there some kind of problem with the way that the vocal folds are vibrating? So here's just a great example of what that looks like. Here's another good video just to see what it kind of looks like from the inside. And on this next slide, you'll see what it's like as the air comes up, it builds right to when it gets enough pressure to push the vocal folds aside and start vibration. And that's how you initiate voicing. All right, now anytime I talk about voice and voice disorders, and people ask me like, oh, who do you take care of? Well, one of the groups that I take care of are professional voice users, but that's just the tip of the iceberg, but I want to start there. So one of the most classic voices that we all, well, at least I adore, I know clearly many people all over the world just adore Frank Sinatra's voice. This is a great essay from 1966 that kind of highlights how crucial the voice is to individuals, and in this case, Sinatra. So I'm going to read it to you. Sinatra was ill. He was the victim of an ailment so common that most people would consider it trivial. But when it gets to Sinatra, it can plunge him into a state of anguish, deep depression, panic, even rage. Frank Sinatra had a cold. Sinatra with a cold is Picasso without paint, Ferrari without fuel, only worse. For the common cold robs Sinatra of that uninsurable jewel, his voice, cutting into the core of his confidence, and it affects not only his own psyche, but also seems to cause a kind of psychosomatic nasal drip within dozens of people who work for him, drink with him, love him, depend on him for their own welfare and stability. A Sinatra with a cold can, in a small way, send vibrations through the entertainment industry and beyond as surely as a president of the United States, suddenly sick, can shake the national economy. And that's an essay from Esquire magazine by Gay Talese, and that was again from 1966. So it's just sort of something so trivial as we think of like a cold can have enormous consequences for someone that relies on their voice for every part of what they do and who they are. So why does voice matter? For a lot of people, voice is their livelihood. And that, again, that's not just singers and actors. Lots of us rely on our voice for our jobs. Voice is also deeply connected to our identity. Isn't it amazing that when you answer the phone, all you can hear like hello, and you know exactly who's calling you, right? Even if you maybe haven't spoken to them in a long time. Voice is also connected for a lot of people to their sense of self-worth. And then, of course, voice is crucial to our communication with one another. So professional voice users, broadly that term is defined as anyone that uses their voice, anyone that relies on their voice in order to make a living. So that, of course, includes singers, actors. Another population that we definitely would consider a professional voice user are teachers. They are talking all day long. Lawyers, clergy people, healthcare providers, sitting in their offices talking to patients all day. Fitness instructors, telemarketers. The list really goes on and on and on. But I want to just emphasize here that the services that we provide in a voice center like this are really not, they're very much not just for professional voice users. We really care about that individual who's having trouble getting through reading that children's book to her grandchild, and her voice is bothering her when she does that. That is so important. We want to make sure that we help people if they're encountering any kind of barrier with their voice when it comes to participating in anything in their voice that's important, anything in their life that's important to them. So I just want to make sure people know the services we provide at a voice center are not exclusively for people that rely on their voices for their job. So voice evaluation and treatment. Here's a picture of some healthy vocal folds. On the left, you see the vocal folds closed, and on the right, you see them open. That's when we're breathing, they open wide up. So I want to start just by saying the kinds of symptoms that warrant a voice evaluation. So if you have a sudden or a gradual change in your voice, maybe it becomes really rough, something like it's rough, or breathy, really breathy, or very strained. If your voice doesn't function the way it used to or the way it needs to, maybe it's become really uncomfortable to talk. Or maybe you find you are constantly clearing your throat, and it's just this incessant habit. Those are all reasons that you would want to come see us at a place like this. So what we do here is something that I work collaboratively with Dr. Lerner, and here's a picture of the two of us in one of the exam rooms. So we work collaboratively, and something that we are so excited about and passionate about. I grew up in Westchester, and Dr. Lerner grew up in Fairfield in Connecticut, and we were both so excited to be able to bring the model that we both trained under to this community. And this model is a multidisciplinary voice clinic. So what happens is you make an appointment to see us. You see, in that first appointment, you'll see Dr. Lerner, and collaboratively, you'll also see me. And I'm the speech-language pathologist specializing in voice. So what we do is together we'll gather the history, get a sense of what's going on. Then we will do laryngeal imaging. And then collaboratively between the laryngologist, and just to explain, a laryngologist is someone who is an ENT, so they did a residency in ear, nose, and throat. And following their residency, after they complete that, they do an additional year or two of training to become specialized in the evaluation and treatment of voice and upper airway disorders. So that's Dr. Lerner's training. And what we do after we assess what's been going on and do the laryngeal imaging is we collaboratively decide what are the appropriate next steps. And when I say collaboratively, I don't just mean me and Dr. Lerner. It's me, Dr. Lerner, and the patient who's there to see us. We need to choose a treatment approach that makes the most sense for them. So we decide, is it going to be medical intervention? Is it going to be voice therapy? Or is it going to be some combination of both? So I want to talk a little bit more about video stroboscopy, so this kind of exam that we do in the office. So there are two types of scopes. You see in the top picture here, there's a scope that goes through the nose and sort of peeks over the back of the throat, and we can look down at the voice. And then there's a different scope that goes in the mouth, and you see that picture here. And what we do and what makes video stroboscopy really special and unique is that you see something like that hummingbird there, right? The wings move so quickly that when we look at them with the naked eye, it's blurry, right? All we see is just this fluttering of movement. We can't actually see what's going on. And when we're assessing the vocal folds on this level for a voice problem, we really need to be able to see how are the vocal folds vibrating. So with video stroboscopy, there's a strobe light that synchronizes with a little microphone that you'd be holding onto your neck while we do the exam. And that strobe light allows us to see the vocal folds moving. It turns it into a version of kind of a slow motion movement so we can actually see how the vibrations are working. And so it's not just this blurry look. So what's cool is when you come to see us here and we do the video stroboscopy, when we're done, we'll actually be able to turn around and have you look at the video and watch the way your vocal folds vibrate. So here's an exam. I want people to be able to see what a video stroboscopy looks like. So this is a fairly healthy voice. This is a female in her 30s. And I'm just going to play this for you and you'll see what vocal folds look like when they're moving.
Recording.
Say he.
So just to orient you of what we're looking at, this is the epiglottis here. I want you to imagine that we are standing on the back of a person's tongue looking down into their throat. So it's the epiglottis here. Those white that we see on the bottom here, those are the vocal folds. And when we're looking down, on our left, we're actually seeing their right side. And on our right, we're seeing their left side. Okay? So I'll keep going.
Good. And now E.
So you'll notice there's some mucus on the vocal folds, right? We all sometimes experience that.
No.
And that's why Dr. Lerner asked this patient to clear her throat because he wanted to see if we could get that mucus away.
Now. Now from low to high. He. I'm going to give you a break.
Recording.
So deep breath in and go from the bottom to the top. Go ahead. A little slower than that. A little slower.
All right, so you get a sense of what it looks like on a video stroboscopy when we see this, the vocal folds vibrating. It's pretty cool. I know I'm biased, but it's a very, very cool. So what happens if, as part of this multidisciplinary voice evaluation, we would get the medical history, we get the voice use, vocal health, what's been going on. Psychosocial history can also inform us. We know that our voice is connected with our life experiences and certainly our emotions as well. And if we decide that you're a good candidate for voice therapy, then I would say, all right, from the exam room, we're going to have you come right across the hall to my office, where we're going to do a voice evaluation from the perspective of a speech-language pathologist, which will start with patient's subjective assessment of what's going on with their voice, then a voice therapist's assessment of how the voice is sounding. We do aerodynamic and acoustic measures, and then we come up with goals and what we want to work on in therapy. So there's a really terrific tool that's a validated tool called the Voice Handicap Index. In our clinic, we mostly use the Voice Handicap Index 10, which is a shorter version than the complete one, which is 30 questions, but we find that that's a lot more doable for patients to fill out. And this asks a variety of questions like, we'll say a statement like, my voice makes it difficult for people to hear me. And patients will circle whether they think that happens never, almost never, sometimes, almost always, or always. And there are 10 questions that probe for different kinds of ways that voice might be impacting a person's everyday life. And then based on those, we quantify them, put a number as a score, and then we can use this. It's a great way to compare pre and post therapy, how things may have changed. And this is a great tool if someone even doesn't do therapy, but they come to see us and maybe they try a medication for something, and we see, did their subjective assessment of how it was impacting their life change from before or after? So that's really useful for us. Another scale I like to use is called the Omni Vocal Effort Scale. And I'll ask people, On a scale of 0 to 10, with 0 being it takes no effort at all to use your voice, and 10 being it takes the most effort you can imagine to use your voice, where would you rate it, right? And that's another good thing that I can ask at the beginning of therapy, and then a few months later when we're done, I can ask the same question and see, has that changed? Then we're going to have the voice pathologist subjective assessment. So there are a couple validated scales and helpful tools here. One of them is called the Gerbas scale, and that's just G for grade, R roughness, breathiness, asthenia, strain, instability. And for each of those parameters, grade is the overall grade, but each of those other parameters of voice, I would rate it with a 0 through 3. And that's something, again, we're going to monitor over the course of time, see if that my perceptual assessment of what I'm hearing, if that changes. There's another great tool, the CAPE V, which also separates into these different parameters. So then you'll come into my office and I'm going to have you do record into my microphone. All right, I'm going to have you at a set distance from the microphone, and I'm going to ask you to read a passage. And it's a standardized passage that's used in clinics all over the country and in a lot of research. And I have you read that out loud, and I can get a bunch of measures from that based on just you reading. And I'm also going to say, okay, now I want you to hold out an ah, and for 5 seconds on a comfortable pitch and loudness. And there are a variety of analyses that I can do on these computer systems that I have on your voice production, which gives us a clearer idea of what's going on, and they can really often support what we're hearing perceptually and what the patient reports to us. There are also aerodynamic measures that we can do. There's something called a phonatory aerodynamic system where you would voice while holding this thing over your face. Harder to do in terms of disinfection right now during this pandemic. There are some really fantastic low-tech aerodynamic measures. So one of them is called maximum phonation time. So I'll say, okay, I want you to hold out an ah sound on a comfortable pitch and loudness, and I want you to hold it as long as you can. And I time people. And ideally, I want to see that time to be between 15 and 25 seconds. That's what's considered within functional limits. And I'll have people do it 3 times, and I'll take their best score. And that's another measure we can assess change over time. And then the final step of the voice assessment is goal development. So while it's important for me to tell you what I think could be a goal, it's almost not very relevant if it doesn't match up with what you, as the patient or the person that's come to us, what you want. So it's really important for me to make sure I am making sure every goal that we come up with is aligned with what you need from your voice in your life. And then finally, we're going to do stimulability testing. And this is a jargony word for basically trial and error. In that first meeting, I'm going to try some different therapy techniques and say, did that make your voice feel better? How did that feel? How does that sound? And based on that, we can determine your potential for improvement in voice therapy, as well as which therapy approach we're going to try. The overall goals for voice therapy are we want to improve vocal quality by balancing the 3 systems of voice production that we spoke about before: respiration, voicing, and resonance. For some people, the goal will be to strengthen the muscles of the larynx. For some people, it's to create a vocal warm-up and cool-down routine. For some people, and for many people actually, we want to either prevent or reverse unhealthy vocal habits. So a metaphor I often use is if you have a pebble stuck in your shoe, you're probably going to start limping. Over time, by limping, you might get a pain in your back, right? So if something is going on, if something's a little out of whack with your voice, you may start compensating for it in ways that are not serving your vocal health. So we want to first be able to identify, is there some sort of compensatory behavior that's not serving you? And can we reverse that? Or if we find a problem that's going on, we want to help you prevent compensating for it in an unhelpful way. Of course, there is no such thing as a small surgery. There are many voice disorders that respond really well to therapy, and if we can achieve your goals without having you go to surgery, that is a huge success, and that's a goal we want to achieve if we can. If that's not in the cards, and we work collaboratively, Dr. Lerner and I, and And then if we decide that medical or surgical intervention is necessary, then the role of voice therapy becomes to maximize the effects of those interventions. And if someone does have surgery, voice therapy will be there so that we can optimize your healing post-surgery. Anytime I talk about speech therapy, I often bring this up. This is a framework that was written about by Dr. Rosenbeck in 2017, who's done a lot of work in dysarthria, disordered speech. And but this framework is really helpful whenever we're talking about establishing a new motor pattern or a new behavior. So the first most important thing, and I have a background in musical theater, so you can see I here have a picture from My Fair Lady, but here on that same topic, it's the idea of how does someone modify something they've been doing and create a new behavior that's sustainable in everyday life. So the first step is you need to recognize a difference. If a person doesn't realize that what they're doing is different from either what they used to do or what other people are doing, then you're not going to get very far, right? A person needs to recognize that what they're doing is different. Then, of course, they have to be willing to change. If a person says, my voice sounds like this and I don't mind it, even if maybe their spouse minds it or someone else in their family or friend group, if the patient's not willing to change, then we're not going to make much progress in therapy. Then we've got to set appropriate goals that are in line with what the patient wants. And then we need to talk therapeutically. So that means even if in the first 5 minutes of my therapy session with you, we are catching up, I want to hear how your week's gone or how the last few weeks have gone. I want to make sure that you know when you're in the therapy room, this whole session is supposed to be valuable for you. So I want you to speak in the way that we're working on right away. So that's something I try to emphasize with patients is, okay, I know we're talking now just about life, but I want you to be using the techniques that we've been establishing. Then I see a patient maybe for 45 minutes once a week, once every other week, for only a couple of months, right? Maybe even less. It would be useless if I didn't empower patients to be able to listen to what they're doing, to evaluate whether they're doing it correctly or not, and then to fix it, right? I am only doing a good job at my work if I empower patients to be their own voice therapist, right? And to listen, evaluate, and self-correct. And that's where that comes in. And then finally, it's important that we keep moving the challenge point. So in therapy, if someone is really good at using the voice technique that we've established, but they can do it in sort of small talk, well, then now's the time for me to make it more challenging. So I need to think of a topic that's either more difficult for the patient to talk about. Maybe in some cases, maybe it's politics, right? In some cases, maybe it's talking about that experience at the grocery store that really bothered them, right? So in any event, I need to make things more cognitively and linguistically challenging so that we're constantly shaping and making the new behavior more established. Now to talk a little bit about structure and timing of voice therapy. It's a pretty short-term therapy. It's typically 4 to 8 sessions, in some cases up to 12. It starts with a learning phase. A patient's going to learn what it is that we want them to learn. Then it's a practice phase, then a generalization phase. Can they do it in different environments, in different contexts? Then the self-efficacy phase. Do they recognize that they can do it on their own and they don't need me? And then maintenance and brush-up sessions. So people may be discharged from therapy, but they'll come back for a session in a few months to make sure that they're still at their goal. And during COVID-19, teletherapy has become a big piece of the puzzle. And what's wonderful is we found that it's really effective. For some people, it has made access to therapy way easier. Some people who may have transportation problems, some people who schedule-wise, it would be really difficult for them to get out of their job for a 45-minute session in the middle of their day. So this has made access to therapy greater for a huge portion of our population. For some, it has been more difficult because maybe they don't have the technology that they need, or maybe they're not comfortable with the technology. So that's something to keep in mind as well. An advantage of teletherapy now is we can take our masks off, right? In in-person therapy, we've got to, for the most part, keep our protective equipment on. So on teletherapy, I can actually say, look at my mouth, watch what I'm doing, and I can watch them do it in that same way. Also, this is kind of just a thought experiment for me, but I also think there's a potential benefit of teletherapy for transferring what we're doing in therapy to people's real lives. And the reason I say that is because there's sometimes when you're working on a skill with a patient in your office and they tell you, gosh, I can do it when you're right there coaching me in your office, but when I go home, for some reason I can't do it. And in teletherapy, they are working on the techniques while they're in their home environment already. So I think it may make transferring it to their regular life a little bit easier. So again, just to carry home these ideas, when do you seek a medical voice evaluation? If you have a sudden change in your voice, it's important to come see us at or a voice clinic, right? Or a change in your voice that doesn't go back to normal within 2 weeks. We want to make sure that there's nothing scary going on, because voice changes and voice problems can be indicative of something more scary, right? There are lots of voice problems that are benign and that aren't a problem, but sometimes voice can be the first clue to something more problematic that needs to be addressed. So I want to just emphasize that you never want to assume that your voice problem is, oh, I just talked too much today. If it's a chronic problem, if you notice a sudden change, or if it's just not getting back to normal within a few weeks, then there's really no harm in coming to see us just so that we can make sure everything is okay. So now I want to talk a little bit about some common voice disorders that we see. So one of the things we see a lot of are benign phonotraumatic lesions. So phonotrauma comes from the Greek word phono, which means sound or voice, and trauma, some kind of injury. So an injury that comes from using your voice, right? So the vocal folds, as you saw before, were in a healthy voice have two straight lines. And this one you'll see even on this still image have these little bumps at the middle part where the vocal folds slam together the hardest. And this can happen just from using your voice in a way that has repetitive collision forces, and it's almost like a little callus right in the middle of the vocal fold. So I want you to watch this video.
Good. See how stiff they become? Breathe in and out. Good. Excellent. Cough. Low pitch.
So those bumps that we see on the vocal folds are making it hard for the vocal folds to close completely, right? There's air escaping on either side, and that can be a problem for people. This individual was actually a singer, and she was having a lot of trouble singing. So these kind of lesions actually respond really well to voice therapy and behavioral voice changes. So we would do therapy. That's what we would do first with someone like this. And if after a few sessions we're not seeing any kind of response, then we'd go back and see the doctor and see, are there any other options we want to consider? But therapy would be the first line of defense for this. And for many people, that does the trick. Other phonotraumatic lesions, people have heard of polyps. So this is an example of a polyp. Usually we'd find them on one side or the other compared to this example, which we see this on both sides. So a polyp would usually be from some kind of vocal accident, maybe yelling at a sporting event, or a really, really violent cough could sometimes cause this. So here are a couple examples of polyps. These kinds of lesions, unless they're very small, typically do require surgery to resolve the voice problem. Another type of problem is glottic insufficiency. So this is when there's a leaky valve and that valve just doesn't close all the way. So vocal fold paresis is one example. That's when the vocal folds they're moving, but either one side or the other or both are just not moving quite as robustly as they ought to be. And another type of voice disorder is vocal fold paralysis, where one side, and in some cases both sides, but one side just is still and only one side is moving. And then that one side can't quite reach to the other side to get closure, and the person's voice could sound really breathy. So here's a picture of that where it looks like this vocal fold is paralyzed in kind of a medial position, and this other side is moving. It can open and close. But the problem here would be that there may be this leaky valve, air coming out and not complete closure. And that can also happen when you have age-related voice changes. So I want to show you a video that's age-related voice changes. This one, the sound is not very loud, but you'll just look at the vocal folds and notice how they really don't come together.
I know, we're almost done. Try not to lean away.
You can tell even just here that they're really not coming together. There's a lot of air escaping, right? So this age-related voice changes that we call presbyphonia, it responds really, really well also to voice therapy kind of exercises that we teach people to strengthen those muscles. And in some cases, this is a case that it's pretty extreme. In some cases, we may say, we'll try therapy, 1 or 2 sessions, say, you know what, we're not getting much closure. In that case, we would go back to the laryngologist and he may do some sort of vocal fold. He could do a vocal fold augmentation, just sort of plump the vocal folds up. But for many, many, many people with presbyphonia, age-related voice changes, their voices respond so beautifully to therapy alone. Another type of voice disorder is something called muscle tension dysphonia. Another word for that is laryngeal hyperfunction, so that people are just working really hard with the muscles around their voices, and it actually makes the voice function less well. A metaphor that I use for this one a lot is if you imagine playing a guitar, if you gently and relaxed strum the guitar, the sound moves beautifully. If you held the strings really tightly and tried to strum that guitar, the sound really would have trouble. The strings would have trouble vibrating, right? So in that same idea, if you were squeezing the muscles in your throat so tight to try to control it or try to make it do something, it actually is counterproductive and is making it harder for the mechanism to work as it needs to. There are 2 types of muscle tension dysphonia. One is called primary muscle tension dysphonia, and this is when there's no problem that we can visualize on the vocal folds, but functionally the person is just holding so tight with their throat, with their voice, so the way they're using their voice isn't working for them. So that's primary. And then secondary muscle tension dysphonia, or secondary laryngeal hyperfunction, is when there is something going on, like age-related voice changes or like those little bumps on the vocal folds. And to compensate for that, a person is squeezing the muscles to try to get that closure to happen. So there's usually, in a lot of the patients that we treat here, there's often some level of hyperfunction, whether that's the problem in and of itself, or it's a response to the problem. So that's something that we target in therapy quite a bit. I want to talk about vocal hygiene. For people that don't have any problem with their voices, these are just going to be helpful things to know about and to think about. So first and foremost, it's valuable to minimize your phonotraumatic voice use. So if it's a habit in your household to yell from room to room, that might not you are giving a presentation or a speech at a party or an event, you probably want to use a microphone, right? We want to minimize using our voice in a way that could damage it. You probably want to avoid yelling and screaming. Another valuable piece of the vocal hygiene puzzle is hydration. Drinking lots of water is going to be really great for your vocal health. That hydrates the voice from the inside. And then if we want to hydrate the voice from the outside, that's where having humidifiers. Here's an example. I have a picture of a personal steam inhaler. Some people love that. Some people use saline nebulizers to hydrate their voice from the outside. And especially during winter, a lot of us know with the heaters on that the air in our homes is a lot drier. So a humidifier is not a bad idea if you feel like your voice is dry. You want to avoid inhaled irritants. So that would be like cigarettes, of course, and anything else you might smoke. Those are going to be irritating to the vocal folds. And inhaled irritants for some people include perfume. If that triggers you and makes you cough, then you probably want to stay away from those kinds of irritants. A warm up and cool down, that's a really amazing tool. If you know you have a huge voice demands that day, it might be valuable for you to hum a little bit before, sort of wake your voice up a little bit in a gentle way. And then when you're done, you might want to hum. And if you feel like you don't have your own set of warm up and cool down and your voice is giving you a problem, that's a reasonable reason why you might come in and say, I think I need to work on this. I think I need to come up with something to help my voice function in the way I need it to. Resting your voice when needed is really valuable. I'm often talking to people about vocal budgeting. Like anything else, like any other muscle in your body, using it a ton is going to tire it out. So finding opportunities to rest your voice and give it an opportunity to recuperate, that's really important. If your voice is feeling really tired after an entire day of talking, well, then see if you can give it a break, right? Give it a little break. You would probably also want to be mindful of acid reflux triggers. If you feel like you know that this makes your reflux really bad, that can also, the acid can come up and irritate the vocal folds. Similarly, if you have a lot of problems with postnasal drip and allergies, those can exacerbate voice problems as well. And then generally speaking, exercise, not only is it great for your whole body, but it actually is great for your voice. Eating well, getting adequate sleep, these are all factors that can also put you in a good place for vocal health. During the COVID-19 pandemic, I often am hearing from a lot of people, and I'm experiencing it personally, that when you wear a mask, it can actually be really fatiguing on your voice. You feel like you have to strain, you have difficulty being heard and understood by people. So a tip that I'm often telling people, and something that I think people can take away from this, is I want you to try, when you're wearing a mask and you feel like people have trouble hearing you, instead of trying to get louder, I want to encourage people to get clearer. So that might mean speaking a little slower and over-exaggerating your articulation. That helps to make your signal more clear. It gives a longer opportunity for the sound to reach the listener's ear, and it prevents you from feeling like you have to push. It gives you something to focus on other than getting really loud. So I want to encourage everyone to give that a try and see what it does for you. And then talking on video platforms, similarly, people are saying, gosh, I don't know what it is, but for some reason on Zoom, I feel like I'm yelling. And interestingly, right now, I'm like, gosh, am I talking too loud? Maybe. And tips I have for you here are, you want to make sure you're using a good microphone. You want to make sure that your speakers are good. You also want to be mindful to monitor yourself. Are you speaking more loudly than you have to, right? And I'm monitoring right now, right? I'm saying, okay, they can hear me. I probably don't have to speak that loud. Another interesting tool that some people have reported is helpful is if you cover one ear, if you put an earplug in one ear, that seems to help people self-monitor a little better and reduce their loudness. So that's something people can try, and that can be pretty subtle on on some kind of Zoom meeting or other video platform. Just put one earplug in one ear and see if that changes how your voice feels after that meeting. I want to talk a little bit. We still have some time left, though. I do want to save some time for questions, but I want to talk to you about the kind of the bread and butter voice therapy techniques that if you came to see us, we would likely start with one of these and then, of course, customize based on what you respond to. But semi-occluded vocal tract exercises are an amazing exercise. So an example of these are lip trills. So I'll show you that. This is because you're exhaling and there's some occlusion, or the exit is made a little smaller, some of the air is reflected backwards. And so there's air coming from below the vocal folds and air coming from above, which almost puts like a little pillow of air between the sides and helps the vocal folds vibrate in the most efficient way possible. If you come to see us, I love these. My personal favorite is blowing bubbles into a cup of water while you're voicing. So I'd likely teach you some version of a semi-occluded vocal tract exercise. It's an amazing warm-up and a cool-down. Another technique we use is something called resonant voice therapy. This is about optimizing our resonance and finding forward focus so we can take some pressure off of the throat. Again, if you for some reason needed to come see us, this is something we'd probably talk a lot about, is optimizing resonance. Resonant voice therapy goes with a traditional hierarchy approach, meaning we start with sounds, we go to syllables, then we go to words, then phrases, then sentences, then into speech. So that's a traditional hierarchy of speech therapy. And of course, there's the freedom to jump around within that hierarchy. But another technique that's pretty new, it was first written about in 2016, is something called conversation training therapy. The goals are similar in that we want to optimize resonance to make it the most efficient and easy voice production. But here you do it right in the context of speech from the very first time. So what I love about this technique is if a person responds well to it, I can teach them it the very first time they meet me, and they can leave the office with a new way to speak. So I want to play a recording. This is someone who came to me. She was a teacher who, her voice didn't bother her, but she felt so much pain associated with how she was using her voice, so much pain in her throat. So this is a recording of her speaking before therapy. And I want you to notice, you're going to hear some glottal fry, which is sort of like down here talking in this part of your voice.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch, with its path high above and its two ends apparently beyond the horizon.
Okay, so for her, that was before. We did 4 sessions of voice therapy where we only did conversation training, where we tried to have her think about speaking in a different way, speak really clearly, and optimize the resonance. And this was how she sounded at the end, and she reported 100% resolution of her throat pain.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is
When
a
the
division
sunlight
of
strikes
white light
sunlight
into
strikes
many
Sorry,
raindrops
beautiful
in the
technical
air,
difficulty.
they
These
act as a
So,
prism and form a rainbow. The rainbow
Ah.
is a division of white light.
Sorry. So I hope that you could hear a difference. For her, it was a subtle change, but it made all the difference in the world. Another technique that we would use for a variety of different things, usually when we're looking at a leaky valve or glottic insufficiency, is increased vocal effort strategies. So this is going to help us strengthen the muscles so that the vocal folds can close better. And a couple examples of some very specific protocols. One is called Forte, Phonation Resistance Training Exercises, and that has been studied robustly in the aging voice population. And another is called the Lee Silverman Voice Treatment, LSVT, and this has been studied a ton in the Parkinson disease population. So in this one, you're thinking that you're going to speak like you're talking in a loud restaurant. You're going to just sort of increase your vocal effort, your vocal energy. So this one, I want to play you the before and after. This was a person who had presbyphonia, age-related voice changes. This is how he sounded on his before therapy.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch, with its path high above and its two ends apparently beyond the horizon.
This is after our 6 sessions.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. They take the shape of a long round arch and with its path high above and its two ends apparently beyond the horizon.
Now, he was really compliant. He was really motivated. He was a singer. He loved to sing. and he felt like he got his voice back. He was just so thrilled. And you can really hear with that one what an enormous improvement he made. Another technique that we use in therapy are manual techniques. So there is something we can do, laryngeal massage, for people that have a lot of tension or pain in their throat. And that's teaching people how to identify the landmarks in their throat and then how to massage them. This can work really well for some people. Okay, there are also neurogenic voice disorders. So this can be in the realm of involuntary muscle movements. So something called laryngeal dystonia. Some people might know it as spasmodic dysphonia. The standard of care for this is actually Botox. You would identify the muscle that's spasming, and Dr. Lerner or another laryngologist would be able to inject Botox into those muscles, which would prevent those muscles from involuntarily spasming and provide some temporary relief. That is the standard of care. The role of voice therapy here is to make sure if there's any compensatory muscle tension, that we help unload that muscle tension so that a person gets the best results from their Botox injection, or if a person decides they don't want to get Botox, to help them get the best voice possible. Voice therapy can also be helpful. Sometimes it's hard to tell the difference between involuntary muscle movement voice disorders and muscle tension dysphonia. And if they get better in therapy, that actually tells us that it was probably in the realm of muscle tension and not a laryngeal dystonia. So that can help us differentially diagnose. Another diagnosis we see is voice tremor. And here, Botox can be a therapy that would be very helpful in this. It's not quite as, it doesn't work quite as well for voice tremor as it does for laryngeal dystonia, but it can be really helpful for many people. But similarly, voice therapy for voice tremor, either in conjunction with Botox or independently, the goal, we can't rid someone of these involuntary movements in therapy, but we can do is try to help them mask their tremor and work with it, work within what's going on. So that would be the goal there. And another population that might seek voice care are gender diverse populations. So this may include trans men, trans women, gender non-conforming individuals, and anyone in the gender diverse population who feels that their voice production does not match their identity. So what we can do in voice therapy is help these people to find a healthy voice production that feels consistent with who they are. So I want to now open things up to questions and discussion. I could talk about this stuff all day. As you can see, I'm very passionate about this. If anyone has any kind of problem with their voice, we would really love to see you at the Voice Center. We'd welcome you to come visit us here. Here's information to call for appointments. That's the Yale Medicine Call Center. You could also email yaleent@yale.edu. And they'd be able to help you there. You want to just tell them that you want an appointment for the Multidisciplinary Voice Center in Greenwich. So you want to see Dr. Lerner and Andrew Keltz. So now it looks like there are a few questions. So I'm going to stop sharing, and go to these questions. So someone asked, does whistling play a role in voice therapy? Interesting question. Thank you for that. So typically, no. So whistling doesn't involve vocal fold movement at all, or at least it shouldn't. There's no coming together of the vocal folds during that. The role that I could actually see whistling playing in voice therapy is if I'm working with individuals who find that their voice demands are so high. I'm thinking for teachers, families with little kids who find that to get people's attention, they're doing a lot of yelling in their house or on the playground if they're a teacher. So I might use whistling as a compensatory strategy here of saying, if you need to get your students' attention or if you need to get your kids' attention, I would encourage you to maybe whistle instead of shouting. So that's the role that I might see for whistling in voice therapy. But thank you for that question. Really interesting. And someone asked if you would start with an ENT doctor before coming to see us at the voice center. So I would say if you know you have a voice specific problem, I would recommend coming to see a laryngologist who is an ENT, but who specializes in voice. So I think you could have a comprehensive experience there, as they could. Most general ENTs don't have video stroboscopy, that the high tech that lets us see the vibration. Some do, but I would say that if you know it's a voice problem, I would come to see a laryngologist in the context of this kind of multidisciplinary clinic. That being said, there are some fantastic ENTs out there who do have a lot of experience in voice, and they may be able to get you set up with the right kind of care team. What I am especially thrilled about in this model that I have here is that when someone sees Dr. Lerner and they are a candidate for voice therapy, they get set up right away in the same office. So it's not, sometimes there are places, if they're not in the same office, then you're given a business card and said, okay, you would benefit from voice therapy, try to get an appointment at one of these places. Here, that process is a little more seamless. I see there's a hand raised. Phyllis and Jay, are you able to, I don't know if you're able to unmute yourself and ask the question, or if you're able to maybe type it into the Q&A. I've got, let me allow you to talk. Hold on. Okay, Phyllis and Jay, if you can ask your question now.
Yes, are you familiar with Lady Windermere syndrome?
That is not
MAC.
That's not a syndrome that I'm familiar with. But certainly, is that something that impacts the voice?
Yes, well, it impacts the lungs, and it also leads to a lot of throat clearing, as you had mentioned, and coughing. So that's why it just sort of does impact the voice in a secondary way.
Yeah. So I'm not specifically familiar with that diagnosis, but anytime there are going to be things that walk into our offices that I'm not familiar with, that I then will go to the literature and try to identify what has been done. Is there anything that we know is helpful with that? And then I would start with anything evidence-based. And then collaboratively, if it's that with, maybe we try to include respiratory and ENT and maybe
Right.
genetics to decide sort of what's the best approach. So I think if those are things you're experiencing, and upper airway problems of chronic cough, as long as if we know chronic cough can happen for a lot of reasons, but if we can rule out that it's not cough caused by a problem in the lungs or the heart or from allergies or reflux, then there are actually behavioral strategies that I can teach people that do help with chronic cough.
Thank you.
Thank you for your question. And I see that Kathy Smith has a question, so I'll give her the mic.
Hi, I was on a ventilizer for 2 weeks, and since then my voice has been sounding like this.
Mm-hmm.
And I was wondering if therapy could help me.
There's a very good chance that it might. So what I would suggest is, and we have been seeing this a lot more frequently now that there have been more people on ventilators in the last few years. I think it's a great idea for us to explore that as an option, for you to make an appointment with the multidisciplinary voice clinic so that we can give you a comprehensive assessment, see what's going on, and then decide whether therapy would be a valuable piece of the puzzle.
Okay.
But I think we would like absolutely. It's definitely something that could be very helpful.
All right, that's good to know.
Yeah. Thank you for your question.
Thank you.
And I saw another. I think there was another question. Let me see. I see. Oh, how deeply does the video stroboscope enter the throat? So that's a great question. So it's sometimes it looks a little scarier than it is. It's actually just for the one that goes in the mouth. It's just going in sort of that much. It just sort of rests on the very back of the tongue and looks down. So it doesn't go in that far, and we guide you through every step of the process. And then the one that goes into the nose, it goes back through the nose and then just sort of hovers over the back. And with that one, typically we spray a little nasal decongestant and lidocaine in the nose a little bit before. So I wouldn't say that it's necessarily the most like super comfortable and fun, but it's not painful, or it ought not to be painful, and it really allows us to get a very clear idea of what may be going on. But we do this. I've had it done on me many times as various people practice, and we say, okay, you're new at this, come try on me. It's really it's not a very invasive exam. It's pretty low risk and allows us to get some really, really valuable images and help us decide what we want to do next. So there. Can we do, great question. So someone asked, can we do this testing during COVID? So we are still doing these kinds of evaluations during the COVID pandemic. Things certainly have changed. Back in the old school days, people would do these exams without masks on. Now, of course, we're wearing N95 respirator masks. We're wearing face shields, and we have air filters in the rooms. We try to screen out people that may be currently experiencing COVID, or that are currently infectious. So we would have them wait until they're no longer infectious to come in. But we are doing these exams during the pandemic, just taking the appropriate precautions. And in some cases, for example, the exam that we do through the nose, the patient can actually keep their mask on just pulled right below their nose, and we can go and look behind there. But we do try to reduce the amount of time that someone takes their mask off, just to keep it as safe for everyone as we can. But in between every visit, the room is disinfected, and so we take that very, very seriously. And then in terms of therapy and the precautions we do, in my office, I have a plexiglass barrier here that sits between me and the patient. When patients are seeing me in person for voice therapy, I wear an N95, a face shield. For most of the session, they would also be wearing their mask. And if there are little moments that it's important that they try something, maybe with blowing bubbles into a cup of water that requires taking the mask off, we try to keep it to a short amount of time. And then another tool, as I mentioned in the presentation, that's been really invaluable during this time is teletherapy, and being able to access people, giving people access to this remotely, so that we can teach them exercises without endangering them or the people who are in our clinics. But thank you for that question. Yeah, it was definitely challenging at the start of the pandemic to figure out how do we continue doing this in a safe way. And I think at this point, obviously it's constantly changing, and suddenly we're always re-questioning, like, is this safe? Is this still safe? But we constantly stay with the science and with the data so that we can keep it as safe for, of course, our patients, and also as safe for everyone that works here as we possibly can. I don't see any more questions, but I am extremely grateful that you all took the time to come here and listen to me talk about something that I am just so passionate about. I wish everyone well. Wish everyone health and happiness. And should you ever encounter any kind of problem with your voice or upper airway, you are always welcome to come visit me and Dr. Lerner here at our clinic. We would just be thrilled to be a part of your care team and help you work toward any of your voice goals. Thank you so much.